distinguished guests, my dear teachers, colleagues, friends, good evening. First of all, I would like to thank the Sri Lanka College of Psychiatrists for giving me this opportunity today. So, greater understanding of childhood bipolar affective disorder came with work done at Lady Ridgeway Hospital for Children with Madam Swarna Wijetunga. So today I would be focusing more on diagnostics rather than the management. So, as we all know, bipolar affective disorder is characterized by multiple mood shifts during the course of the lifetime. And the diagnostics is carried out by classifying patient experiences or observable behaviors according to DSM or ICD. Interestingly, when it comes to the diagnostic evolution across a century, starting from 1921, Emil Kraepelin coining the term manic depressive insanity, we have evolved very little, where we are talking about bipolar affective disorder in 2021, according to phenomenology. So, with that food for thought, let's go on to epidemiology and the burden. Prevalence in the UK is about 22% of the population, and in US about 2.8%. And with global data extrapolated, let's say we have around 200,000 population in Sri Lanka. So suicidal rates estimated to be over 10%, and suicidal attempts at 34%. And there is a large healthcare burden. Going on to etiology, there is a 10 to 25% increase in tendency to develop bipolar affective disorder with a first-degree family member. Heritability stands at about 70 to 80%. The genome-wide association studies have found multiple candidate genes, and indeed, it's multifactorial. So you have multiple risk genes with multifactorial insults, usually early life insults, trauma. You have these risk genes undergoing epigenetic changes. With a second or third hit, these disordered genes would express themselves to have the disorder being manifesting. So, when it comes to parents with bipolar affective disorder, attachment disruption and trauma has been quite common. Attachment disruption has been significantly seen in adolescents with a parent with bipolar disorder. And conversely, adults with major psychiatric illness have had significantly higher rates of attachment disruption. So, disrupted attachment would give rise to a perfect niche for these genetic manipulations to occur in vulnerable children and adolescents. So, when it comes to trauma, young individuals at high familial risk had shown significantly greater frequency and severity of physical abuse when compared to healthy controls. And in this study, they had also displayed greater severity of prodromal symptoms than the other groups. And youth with bipolar disorder and familial risk had shown greater levels of child trauma exposures. So these are amounting to child trauma. So this slide is actually laden to say that it's high time that we go beyond phenomenology and diagnosing patients with their experiences. The neuropathological process can be translated into phenotypes, and these combinations can be utilized in diagnostics. Going on to age at onset. This is one of the largest studies done, the STEP-BD, the Systematic Treatment Enhancement Program for Bipolar Disorder. They had studied over 3,600 patients with bipolar disorder and found that 30% had had prepubertal onset, and 68% had had their onset by 18 years. And this had been replicated by this study as well, the NIMH Bipolar Disorder Genetic Association. A similar pattern is seen. So, what is this fuss about childhood bipolar disorder? It is a master of disguise in its presentation. It can be hidden between many diagnoses fulfilling syndromic criteria. And one needs careful examination at the onset, the evolution, response to medication, and identifying dimensions in order to come to a diagnosis. Why is it important to diagnose early? There is a greater loss of recovery, greater disease burden. It's estimated that over 5 to 10 years are lost prior to diagnosis. And each lost year has been calculated to have about 10% capacity loss. And there has been noted to have greater harm with use of antidepressants. They're noted to be in less time in euthymia, noted to have more recurrences, high suicidality, greater substance use, and more functional impairment. And they are more likely to have been through childhood trauma, a parent with a mental illness, multiple comorbidities, therefore beyond treatment for them, and which would confound the diagnosis, and they would have been misdiagnosed and mismanaged. So I would like to lay down here a case experienced at Lady Ridgeway Hospital for Children. Miss D, 13 years, an intellectually normal child with a history of intra-uterine and growth restriction. She received 7 diagnoses over 5 years. OCD, trichotillomania, ADHD, ODD, going on to conduct disorder, binge eating disorder, recurrent depressive disorder, and emerging borderline personality disorder. So the onset of symptoms was at 8 years. She was a terror and a joker in the class. She had frequent meltdowns at home. Extreme anxiety with obsessions and compulsions, took 4 to 5 hours a day. She would binge eat in the evening latterly, and there was a sudden need for sleep in the class, and she would sleep late. She would sleep late with nightmares. She experienced frequent suicidal ideation. There was a significant functional impairment, and she was on multiple psychotropes. And she was extensively investigated, including neuroimaging and endocrine workup. So this is a kind of a pictorial representation of the course of her illness and how the diagnosis evolved over time. So her course of illness was reviewed to minute detail, identifying responses to escalating antidepressants and stimulants. She displayed manic and depressive symptoms, although they did not meet duration criteria. We identified extreme sudden daytime sleeping and nighttime reduced need for sleep as circadian rhythm disturbances. We identified binge eating as an appetitive drive disturbance and identified that oppositional defiance is upon protecting territory. She did fulfill criteria for mania, although she did not fulfill the duration criteria. So she was diagnosed with childhood onset bipolar affective disorder not otherwise specified and commenced on a mood stabilizer while omitting all her medications. Her mood symptoms resolved within 2 to 3 months. Interestingly, her anxiety disorders, including the OCD and trichotillomania, remitted. She was no longer hyperactive, so no longer met criteria for ADHD. She no longer binge ate, so no longer met criteria for an eating disorder. She was no longer oppositional or defiant. Her CGAS scores rose to 70 to 80. However, some deficits continued, including executive function difficulties and peer relationship deficits, and she has been euthymic since. So when it comes to the diagnostic entities in childhood bipolarity in relation to the classifications, you do find bipolar 1 fulfilling criteria for mania, for the duration criteria. And you do find children fulfilling criteria for BP2, including the duration criteria. However, there is a majority, I would say, who would not fulfill criteria, especially the duration criteria. They may display cycles as short as 4 hours and may have multiple cycles during the day. So commonly what we see in our practice is that we see children are within the depressive pole in the morning and would fulfill criteria for mania or hypomania during the evening hours of the day. And these alterations are conceptualized as cycles within a mood episode. So the stability of the diagnosis of these children who are being diagnosed as bipolar disorder not otherwise specified, there has been studies which showed that the children had the same symptom burden and functional impairment throughout the course of the illness. So the difficulties in diagnosis of child bipolar disorder comes with trying to meet the symptoms with adult experiences laden criteria. So it also comes with having a comorbid diagnosis is usually the norm rather than the exception in children and adolescents. And they commonly have other neurodevelopmental and biological deficits which will have their own behavioral manifestations which would cloud the diagnosis. So I will try to touch upon some of these diagnoses. Attention deficit hyperactivity disorder is quite common. Literature speaks of having 50 to 70%. Our research also supports this. They have a likelihood of earlier onset, prevalence of other comorbidities, worsened course and prognosis with greater suicidality and substance use disorders. When it comes to anxiety, adult patients, over 14,000 adult patients had been studied and had shown over 45% have a syndromic anxiety disorder. Obsessive compulsive disorder criteria met 23% of those with bipolar affective disorder. Obsessional and compulsive symptoms meeting syndromic criteria, interestingly, may absolve when the mood episode settles. Higher OCD and hoarding prevalence rates are seen in children. This was again seen in our research. They may arise with an acute onset, with a significant symptom burden, and they may show rapid response to antidepressants. And again, greater symptom burden during the course of the illness, with a poorer course and poorer functional outcomes. Oppositional defiant disorder usually may not meet criteria once a mood episode settles. Autism spectrum disorders, about 8 to 10% would develop bipolar disorder. And they may have earlier onset of mood symptoms and a larger symptom burden with elevated rates of comorbid obsessive compulsive disorders again. They may show social withdrawal and low reactivity of negative mood states. Children and adolescents with autism spectrum disorder commonly display perceptual abnormalities. They have perceptual processing, sensory processing difficulties, which would complicate the picture when it is comorbid with bipolar disorder. We may treat them as psychotic disorders. And between 12 to 20% of autistic individuals may have catatonia type deteriorations, where They may display bradykinesias, difficulties in initiating and following up of activities, reduced speech, regression of skills. And our experience has shown that these individuals have catatonic symptoms comorbid to bipolar disorder. And the presence of these catatonic symptoms may confound the presentation of bipolarity. So they commonly have other neurodevelopmental and biological processors, deficits in processors, like cognitive deficits, commonly have executive function difficulties. They can have sleep deficits with nightmares and other parasomnias. They can have motor regulation, coordination difficulties. They can have thermoregulation difficulties, which has been studied as a biomarker for a certain phenotype of childhood bipolar. And they have commonly sensory processing difficulties. So the behavioral manifestations that would occur with these difficulties would confound again the underlying mood disorder. So with all of these difficulties coming in, it is recommended that children and adolescents should be diagnosed beyond the categorical diagnosis that we usually employ for adults. So a dimensional approach to the formulation is highly recommended. So the dimensions are invariably the manic, hypomanic, and depressive symptom dimensions. And to study for appetitive, look for appetitive drive disturbances, like eating habits, hypersexuality. Then look for circadian rhythm disturbances. Identify differences or psychomotor activity levels and energy during the course of the day, whether they fit into a pole where the child may be depressed or manic or hypomanic at some point during the day. Then look for anxiety-related dimensions, including obsessionality. We may have to tease out complex PTSD because trauma is quite common in these children. Other comorbidity assessment and patterns in symptom burden, neurocognitive dimensions, and other developmental and biological deficits. So going within a formulation that encompasses a dimensional approach would gear us towards a diagnosis. So the Child Bipolar Questionnaire has been validated to the Sri Lankan population with excellent sensitivity and specificity. So it's provided free of usage for Sri Lanka, and it can also give an understanding of the severity of the disorder. It's able to screen for comorbid ADHD along with bipolar disorder. So the tool has 65 stems, and it has separate domains for DSM diagnosis of mania, depression, as also anxiety. It identifies cognitive deficits related to bipolar disorder, identifies circadian rhythm disturbances, appetitive drive disturbances, and also other neurodevelopmental deficits. So, going forward, I think it's high time we go beyond adult experience-laden classifications. High time that we go beyond phenomenological classifications to more biological classifications. Then the importance of early diagnosis and management cannot be emphasized, as also perinatal mental health and infant mental health realms to be considered, especially in parents with psychiatric illness, where the genetic vulnerability sits in to reduce the burden to transmit the illness across to the next generation. Thank you.